Question 1. A 72-year-old female with a history of chronic kidney disease presents with fatigue, muscle cramps, and tingling in her fingers and around her mouth. Her labs show serum calcium of 7.2 mg per deciliter, albumin 3.5 g/dl, phosphate 6.0 mg per deciliter, and creatinine 3.2 mg per deciliter. Which nursing action is the priority? A. Encourage high calcium foods like dairy. B. Initiate seizure precautions. C. Administer 4 magnesium sulfate. D. Apply heat to the patient's extremities. Answer, B. Initiate seizure precautions. Rationale: hypocalcemia increases neuromuscular excitability, which can progress to tetany and seizures. Priority interventions include seizure precautions and monitoring airway. Oral calcium or dietary measures are important but not the immediate safety priority. Magnesium is not indicated here, and heat does not prevent tetany. Question 2. A 60-year-old male with metastatic prostate cancer complains of nausea, constipation, and confusion. Serum calcium is 13.5 mg per deciliter, creatinine 2.0 mg per deciliter, and EKG shows shortened QT interval. Which is the most critical nursing intervention? A. Encourage oral hydration. B. Administer 4-bisphosphonate as ordered. C. Place on fall precautions. D. Prepare for emergency dialysis. Answer, C. Place on fall precautions. Rationale: this patient is experiencing hypercalcemia of malignancy. Normal calcium is 8.5 to 10.5 mg/dl. With a serum calcium level of 13.5 mg per deciliter, he is in a hypercalcemic crisis, which significantly affects neurological and musculoskeletal function. Question 3. A patient with hypoparathyroidism presents with carpopedal spasms and positive Chvostek's and Trousseau's signs. Which lab abnormality do you anticipate? A. Hypercalcemia. B. Hypocalcemia. C. Hypermagnesemia. D. Hyperkalemia. Answer, B. Hypocalcemia. Rationale: hypoparathyroidism reduces PTH, which decreases calcium reabsorption and bone mobilization, causing hypocalcemia. Chvostek's and Trousseau's signs are classic indicators of neuromuscular excitability due to low calcium. Question 4. A 55-year-old postthyroidectomy patient develops tingling around the mouth and numbness in the fingers. Serum calcium is 6.8 mg per deciliter. Which intervention should the nurse anticipate? A. 4-calcium gluconate. B. Oral phosphate binder. C. 4-furosemide. D. Initiate high-sodium diet. Answer, A. 4-calcium gluconate. Rationale: acute symptomatic hypocalcemia after thyroid surgery is treated with 4-calcium gluconate. Oral phosphate binders and furosemide are not immediate treatments, and sodium intake does not directly affect acute calcium correction. Question 5. A patient with chronic alcoholism presents with tetany and seizures. Labs reveal serum calcium 7.0 mg per deciliter, albumin 2.8 g/dl, and magnesium 1.2 mg per deciliter. Which electrolyte correction should be addressed first? A. Calcium. B. Magnesium. C. Potassium. D. Sodium. Answer, B. Magnesium. Rationale: hypomagnesemia can impair PTH secretion and worsen hypocalcemia. Correcting magnesium first is essential for effective calcium correction. Calcium may not respond until magnesium is normalized. Question 6. A patient with multiple myeloma has serum calcium 14.2 mg per deciliter, complaints of polyuria, confusion, and constipation. Which nursing priority is most appropriate? A. Administer oral calcium supplements. B. Initiate 4 hydration with normal saline. C. Encourage bed rest to prevent fractures. D. Prepare for a calcium infusion. Answer: B. Initiate 4 hydration with normal saline. Rationale: hypercalcemia causes dehydration and increases risk for renal failure. For fluids help dilute calcium and improve renal excretion. Calcium supplements worsen hypercalcemia. Bedrest is supportive but not priority. Question 7. A 68-year-old patient with chronic pancreatitis shows serum calcium 7.0 mg per deciliter and albumin 3.0 g/dl. The patient reports muscle cramps and paresthesia. Which clinical manifestation requires immediate action? A. Constipation. B. Positive Chvostek sign. C. Prolonged QT interval on ECG. D. Mild confusion. Answer: C. Prolonged QT interval on ECG. Rationale: hypocalcemia prolongs the QT interval, increasing the risk for ventricular arrhythmias. While neuromuscular signs are important, cardiac monitoring and intervention are priority due to potential fatal arrhythmias. Question 8. A patient presents with hyperparathyroidism, complaining of fatigue, kidney stones, and nausea. Labs show calcium 12.8 mg per deciliter and phosphate 2.2 mg per deciliter. Which intervention is priority? A. Administer phosphate binder. B. Encourage high calcium diet. C. Monitor for dysrhythmias. D. Initiate for potassium. Answer: C. Monitor for dysrhythmias. Rationale: hypercalcemia can cause shortened QT interval and cardiac dysrhythmias. Monitoring cardiac function is a priority. Dietary calcium should not be increased. Phosphate binders are used if phosphate is high, which it is not. Question 9. A 50-year-old patient with vitamin D deficiency develops numbness, tetany, and seizures. Which treatment should the nurse expect to be prescribed? A. Oral calcium and vitamin D supplementation. B. 4-phosphate. C. 4-furosemide. D. Restrict oral fluids. Answer: A. Oral calcium and vitamin D supplementation. Rationale: vitamin D deficiency leads to hypocalcemia. Treatment includes calcium replacement and vitamin D to enhance absorption. 4-phosphate or furosemide would not correct the underlying deficiency, and fluid restriction is unnecessary. Question 10. A patient with hypercalcemia secondary to sarcoidosis reports muscle weakness, fatigue, and constipation. Serum calcium is 13.0 mg per deciliter. The nurse should anticipate which lab abnormality? A. Elevated PTH. B. Low phosphate. C. Elevated vitamin D, calcitriol. D. Low magnesium. Answer: C. Elevated vitamin D, calcitriol. Rationale: sarcoidosis causes hypercalcemia via increased conversion of vitamin D to its active form, calcitriol, by granulomatous tissue. PTH is usually suppressed, phosphate may be normal, and magnesium is unrelated. Question 11. A 64-year-old female with a history of breast cancer metastatic to bone presents with lethargy, anorexia, and decreased deep tendon reflexes. Her calcium level is 14.8 mg per deciliter. The nurse notes the patient becomes increasingly drowsy and difficult to arouse. Which is the priority intervention? A. Administer 4-loop diuretics. B. Initiate continuous cardiac monitoring. C. Administer calcitonin as prescribed. D. Encourage ambulation. Answer: B. Initiate continuous cardiac monitoring. Rationale: severe hypercalcemia, greater than 14 mg per deciliter, can cause life-threatening cardiac dysrhythmias. While calcitonin and diuretics help lower calcium, cardiac monitoring is the priority due to immediate risk of fatal arrhythmias. Question 12. A postoperative patient following total thyroidectomy develops stridor, difficulty breathing, and perioral numbness. Which action should the nurse take first? A. Administer 4-calcium gluconate. B. Call rapid response team. C. Elevate head of bed. D. Apply oxygen via nasal cannula. Answer: B. Call rapid response team. Rationale: stridor indicates airway compromise, a life-threatening emergency often due to severe hypocalcemia causing laryngospasm. Immediate escalation is priority before medication administration. Question 13. A patient with chronic renal failure is noted to have hypocalcemia and hyperphosphatemia. Which mechanism explains this imbalance? A. Increased calcium excretion in urine. B. Decreased vitamin D activation. C. Excess parathyroid hormone secretion. D. Increased intestinal calcium absorption. Answer: B. Decreased vitamin D activation. Rationale: kidneys activate vitamin D. In renal failure, decreased activation leads to reduced calcium absorption from the gut, causing hypocalcemia and secondary hyperparathyroidism. Question 14. A patient with hypercalcemia is receiving 4-normal saline and furosemide. Which finding indicates the therapy is effective? A. Increased urine output. B. Serum calcium decreasing from 13.5 to 10.5 mg per deciliter. C. Decreased blood pressure. D. Reduced edema. Answer: B. Serum calcium decreasing from 13.5 to 10.5 mg per deciliter. Rationale: the goal of treatment is to reduce serum calcium levels. While urine output may increase, the definitive indicator of effectiveness is normalization of calcium levels. Question 15. A nurse is caring for a patient with severe hypocalcemia. Which assessment finding requires immediate intervention? A. Hyperactive bowel sounds. B. Laryngospasm. C. Positive Trousseau's sign. D. Anxiety. Answer: B. Laryngospasm. Rationale: laryngospasm can obstruct the airway and is life-threatening. It requires immediate intervention. Other symptoms indicate hypocalcemia but are not immediately fatal. Question 16. A patient with prolonged immobilization after spinal cord injury develops hypercalcemia. Which is the primary cause? A. Increased intestinal calcium absorption. B. Bone resorption due to lack of weight bearing. C. Increased renal calcium excretion. D. Decreased parathyroid hormone. Answer: B. Bone resorption due to lack of weight bearing. Rationale: immobilization leads to increased bone breakdown, releasing calcium into the bloodstream, resulting in hypercalcemia. Question 17. A patient with hypocalcemia is receiving 4-calcium. Which precaution is most important during administration? A. Administer rapidly via 4-push. B. Monitor cardiac rhythm continuously. C. Mix with bicarbonate solution. D. Encourage oral intake. Answer: B. Monitor cardiac rhythm continuously. Rationale: 4-calcium can cause cardiac arrhythmias if administered improperly. Continuous cardiac monitoring is essential during infusion. Question 18. A 45-year-old patient presents with kidney stones, bone pain, and abdominal discomfort. Lab results show calcium 13.2 mg per deciliter. Which condition is most likely? A. Hypoparathyroidism. B. Hyperparathyroidism. C. Vitamin D deficiency. D. Acute pancreatitis. Answer: B. Hyperparathyroidism. Rationale: classic signs of hyperparathyroidism include stones, bones, groans, and psychiatric overtones associated with hypercalcemia. Question 19. A patient with hypocalcemia is being monitored. Which ECG change should the nurse expect? A. Shortened QT interval. B. Prolonged QT interval. C. Peaked T waves. D. Widened QRS complex. Answer: B. Prolonged QT interval. Rationale: hypocalcemia prolongs the QT interval, increasing risk of torsades de pointes and other ventricular arrhythmias. Question 20. A patient with hypercalcemia is at risk for which complication due to decreased neuromuscular excitability? A. Seizures. B. Tetany. C. Respiratory depression. D. Hyperreflexia. Answer: C. Respiratory depression. Rationale: hypercalcemia decreases neuromuscular excitability, leading to muscle weakness and potential respiratory depression. Hypocalcemia causes tetany and seizures. Question 21. A 70-year-old patient with advanced lung cancer presents with confusion, dehydration, and muscle weakness. Labs reveal calcium 15.2 mg per deciliter. The provider prescribes 4-normal saline followed by calcitonin. Which assessment finding indicates the patient is responding to therapy? A. Increased deep tendon reflexes. B. Improved level of consciousness. C. Development of diarrhea. D. Presence of Chvostek's sign. Answer: B. Improved level of consciousness. Rationale: severe hypercalcemia causes neurological depression, confusion, lethargy. Improvement in mental status indicates effective treatment. Increased reflexes and Chvostek's sign indicate hypocalcemia, not improvement. Question 22. A postoperative patient after parathyroidectomy suddenly reports tingling in the lips and fingers. The nurse observes muscle twitching and a positive Trousseau's sign. What is the most appropriate immediate intervention? A. Administer oral calcium carbonate. B. Prepare for calcium gluconate. C. Encourage deep breathing exercises. D. Place patient in Trendelenburg position. Answer: B. Prepare for calcium gluconate. Rationale: acute hypocalcemia after parathyroid surgery can be severe and requires rapid 4-calcium replacement. Oral calcium is too slow for acute symptoms. Question 23. A patient with chronic kidney disease has hypocalcemia despite adequate dietary intake. Which additional medication would the nurse anticipate? A. Calcitriol, active vitamin D. B. Furosemide. C. Sodium bicarbonate. D. Phosphate supplements. Answer: A. Calcitriol, active vitamin D. Rationale: CKD reduces conversion of vitamin D to its active form. Calcitriol helps increase calcium absorption from the gut and correct hypocalcemia. Question 24. A patient with hypercalcemia is placed on loop diuretics after hydration therapy. Which electrolyte imbalance should the nurse monitor closely? A. Hyperkalemia. B. Hypokalemia. C. Hypermagnesemia. D. Hypernatremia. Answer: B. Hypokalemia. Rationale: loop diuretics like furosemide promote excretion of potassium along with calcium, increasing the risk of hypokalemia. Question 25. A nurse is assessing a patient with suspected hypocalcemia. Which technique is used to elicit Trousseau's sign? A. Tap the facial nerve in front of the ear. B. Inflate blood pressure cuff above systolic pressure. C. Ask the patient to hyperventilate. D. Assess plantar reflex. Answer: B. Inflate blood pressure cuff above systolic pressure. Rationale: Trousseau's sign is elicited by occluding blood flow with a BP cuff, causing carpopedal spasm in hypocalcemia. Question 26. A patient with hypercalcemia is at risk for renal complications. Which assessment finding indicates worsening kidney involvement? A. Decreased urine-specific gravity. B. Increased urine output. C. Elevated creatinine levels. D. Clear urine. Answer: C. Elevated creatinine levels. Rationale: hypercalcemia can cause nephrocalcinosis and renal failure. Rising creatinine indicates worsening kidney function. Question 27. A patient receiving massive blood transfusions begins to develop tingling and muscle spasms. Which is the most likely cause? A. Hyperkalemia. B. Citrate-binding calcium causing hypocalcemia. C. Increased sodium levels. D. Elevated phosphate. Answer: B. Citrate-binding calcium causing hypocalcemia. Rationale: blood products contain citrate, which binds calcium and can lead to acute hypocalcemia during massive transfusions. Question 28. A patient with severe hypercalcemia is receiving 4 bisphosphonates. Which outcome indicates effective treatment? A. Increased calcium excretion in stool. B. Reduced bone resorption. C. Increased PTH secretion. D. Decreased vitamin D activation. Answer: B. Reduced bone resorption. Rationale: bisphosphonates inhibit osteoclast activity, reducing bone breakdown and lowering serum calcium levels. Question 29. A patient presents with hypocalcemia and reports recent thyroid surgery. Which additional finding would the nurse expect? A. Bradycardia with shortened QT interval. B. Hyperreflexia and muscle twitching. C. Constipation and lethargy. D. Decreased neuromuscular excitability. Answer: B. Hyperreflexia and muscle twitching. Rationale: hypocalcemia increases neuromuscular excitability, leading to hyperreflexia, twitching, and tetany. Question 30. A nurse is educating a patient with chronic hypocalcemia. Which dietary choice indicates correct understanding? A. Spinach and bran cereal only. B. Milk, cheese, and yogurt. C. Processed meats and canned soups. D. Bananas and oranges. Answer: B. Milk, cheese, and yogurt. Rationale: dairy products are rich in calcium and are recommended for patients with hypocalcemia. Spinach contains calcium but also oxalates that reduce absorption. Question 31. A 66-year-old male with prolonged immobilization following a stroke is admitted with confusion, anorexia, and constipation. Laboratory findings reveal calcium 13.9 mg per deciliter, phosphorus 2.4 mg per deciliter, and normal PTH levels. Which pathophysiological mechanism best explains this patient's condition? A. Increased gastrointestinal calcium absorption. B. Decreased renal calcium excretion. C. Accelerated osteoclastic bone resorption. D. Increased calcitonin secretion. Answer: C. Accelerated osteoclastic bone resorption. Rationale: immobilization leads to increased bone breakdown due to lack of mechanical stress, releasing calcium into circulation. This causes hypercalcemia independent of PTH. Question 32. A patient with severe hypocalcemia is receiving 4-calcium gluconate. During administration, the nurse notes infiltration at the 4 site. What is the priority action? A. Slow the infusion rate. B. Stop the infusion immediately. C. Apply cold compress. D. Flush the line with saline. Answer: B. Stop the infusion immediately. Rationale: calcium is a vesicant and can cause tissue necrosis if extravasation occurs. The infusion must be stopped immediately to prevent further tissue damage. Question 33. A 58-year-old female with hyperparathyroidism reports bone pain and recurrent kidney stones. Labs show calcium 12.5 mg per deciliter and phosphorus 2.0 mg per deciliter. Which additional finding would the nurse anticipate? A. Increased bone density. B. Elevated PTH levels. C. Decreased urinary calcium. D. Prolonged QT interval. Answer: B. Elevated PTH levels. Rationale: primary hyperparathyroidism leads to increased PTH, causing bone resorption, hypercalcemia, and hypophosphatemia. Question 34. A critically ill patient develops acute hypocalcemia with tetany. Which medication order should the nurse question? A. 4-calcium gluconate. B. Magnesium sulfate. C. Sodium bicarbonate. D. Vitamin D supplementation. Answer: C. Sodium bicarbonate. Rationale: sodium bicarbonate can worsen hypocalcemia by increasing calcium binding to albumin, reducing ionized calcium levels and exacerbating symptoms. Question 35. A patient with hypercalcemia secondary to malignancy is receiving aggressive 4-hydration. Which complication should the nurse monitor for during therapy? A. Fluid overload. B. Hypoglycemia. C. Hypernatremia. D. Metabolic alkalosis. Answer: A. Fluid overload. Rationale: aggressive 4-fluid administration, especially in older adults or those with cardiac compromise, increases the risk of fluid overload. Question 36. A patient with chronic hypocalcemia is being discharged. Which statement indicates a need for further teaching? A. I will take my calcium supplements with meals. B. I should avoid excessive caffeine intake. C. I will limit foods rich in vitamin D. D. I should report muscle twitching immediately. Answer: C. I will limit foods rich in vitamin D. Rationale: vitamin D enhances calcium absorption. Patients with hypocalcemia should not restrict vitamin D, they often require supplementation. Question 37. A patient with hypercalcemia is noted to have decreased bowel sounds and abdominal distension. Which condition is the nurse most concerned about? A. Diarrhea. B. Paralytic ileus. C. Peptic ulcer disease. D. Gastroenteritis. Answer: B. Paralytic ileus. Rationale: hypercalcemia reduces smooth muscle activity, leading to decreased GI motility and risk of paralytic ileus. Question 38. A patient with hypocalcemia develops seizures. Which intervention should the nurse implement first? A. Administer 4-calcium. B. Protect airway and ensure safety. C. Place patient in supine position. D. Administer benzodiazepines. Answer: B. Protect airway and ensure safety. Rationale: during seizures, airway protection and injury prevention are the priority, ABC principle. Calcium correction follows stabilization. Question 39. A patient with hypercalcemia has an ECG showing shortened QT interval. Which additional assessment finding is most consistent with this condition? A. Hyperactive reflexes. B. Muscle spasms. C. Lethargy and weakness. D. Positive Trousseau's sign. Answer: C. Lethargy and weakness. Rationale: hypercalcemia decreases neuromuscular excitability, leading to weakness and lethargy. The other options are associated with hypocalcemia. Question 40. A nurse is evaluating a patient at risk for hypocalcemia after neck surgery. Which finding would require immediate intervention? A. Mild hoarseness. B. Slight neck swelling. C. Inspiratory stridor. D. Pain at incision site. Answer: C. Inspiratory stridor. Rationale: stridor indicates airway obstruction, often due to laryngospasm from hypocalcemia. This is a medical emergency requiring immediate action. Question 41. A 62-year-old patient with a history of chronic kidney disease and secondary hyperparathyroidism presents with bone pain and muscle weakness. Laboratory results reveal calcium 8.0 mg per deciliter, phosphate 6.5 mg per deciliter, and elevated PTH. Which intervention is most appropriate to address the underlying imbalance? A. Administer calcium gluconate 4-push. B. Initiate phosphate binders with meals. C. Encourage high-phosphate diet. D. Restrict vitamin D intake. Answer: B. Initiate phosphate binders with meals. Rationale: in CKD, phosphate retention leads to hypocalcemia and secondary hyperparathyroidism. Phosphate binders reduce phosphate absorption, helping normalize calcium levels. Question 42. A patient with hypercalcemia is receiving calcitonin. Which finding indicates the medication is working effectively? A. Increased bone pain. B. Decreased serum calcium levels. C. Increased urinary retention. D. Elevated PTH levels. Answer: B. Decreased serum calcium levels. Rationale: calcitonin lowers serum calcium by inhibiting bone resorption and increasing renal excretion of calcium. Question 43. A patient develops hypocalcemia following acute pancreatitis. What is the primary mechanism causing this imbalance? A. Increased renal calcium loss. B. Fat necrosis binding calcium. C. Increased intestinal excretion. D. Decreased albumin production. Answer: B. Fat necrosis binding calcium. Rationale: in pancreatitis, fat necrosis binds calcium, saponification, leading to decreased serum calcium levels. Question 44. A nurse is caring for a patient with severe hypercalcemia. Which neurological finding is most concerning and requires immediate intervention? A. Mild confusion. B. Lethargy. C. Coma. D. Fatigue. Answer: C. Coma. Rationale: severe hypercalcemia can depress the central nervous system leading to coma, which is life-threatening and requires immediate intervention. Question 45. A patient with hypocalcemia is being monitored for complications. Which respiratory finding would indicate worsening condition? A. Increased respiratory rate. B. Shallow breathing. C. Stridor. D. Crackles. Answer: C. Stridor. Rationale: stridor indicates laryngospasm due to hypocalcemia, which can obstruct the airway and is a medical emergency. Question 46. A patient with hypercalcemia is prescribed a low-calcium diet. Which food selection indicates correct understanding? A. Cheese omelette. B. Sardines with bones. C. Grilled chicken with green beans. D. Yogurt smoothie. Answer: C. Grilled chicken with green beans. Rationale: patients with hypercalcemia should avoid calcium-rich foods like dairy and sardines. Lean protein and vegetables are appropriate choices. Question 47. A nurse is reviewing ECG changes in a patient with calcium imbalance. Which finding is most consistent with hypercalcemia? A. Prolonged QT interval. B. Flattened T waves. C. Shortened QT interval. D. Peaked T waves. Answer: C. Shortened QT interval. Rationale: hypercalcemia shortens the QT interval, while hypocalcemia prolongs it. Question 48. A patient receiving long-term corticosteroid therapy develops hypercalcemia. Which mechanism explains this condition? A. Increased calcium absorption in the intestines. B. Increased bone resorption. C. Decreased renal calcium excretion. D. Increased vitamin D activation. Answer: B. Increased bone resorption. Rationale: corticosteroids can lead to bone breakdown, osteoporosis, releasing calcium into the bloodstream. Question 49. A patient with hypocalcemia is receiving calcium supplements. Which instruction is most important for optimal absorption? A. Take with high-fiber foods. B. Take with vitamin D. C. Take on an empty stomach only. D. Avoid taking with water. Answer: B. Take with vitamin D. Rationale: vitamin D enhances calcium absorption in the gastrointestinal tract, improving treatment effectiveness. Question 50. A critically ill patient develops both hypocalcemia and hypomagnesemia. Despite calcium replacement, calcium levels remain low. What is the best explanation? A. Calcium is being excreted too rapidly. B. Magnesium deficiency impairs PTH secretion. C. Vitamin D levels are too high. D. The kidneys are retaining calcium. Answer: B. Magnesium deficiency impairs PTH secretion. Rationale: magnesium is essential for PTH release. Without correcting hypomagnesemia, calcium levels will not normalize despite supplementation. That's it for today's session. If you found this helpful, make sure you like, share, and subscribe so you don't miss the next set of challenging NCLEX style questions. Keep practicing, stay consistent, and remember, mastery comes from repetition, not luck. See you in the next video.